Banners, Dr. Lalsa Irfan, and Dr. Raju who have taken the trouble to be here. We have others like Prasanna Tivarkis from LIMATS in the audience, and I'm sure some others have joined. I have a request, especially for those of you who are videotaping the last lecture. Just want to point out that the patient videos are confidential, they are meant for teaching, they are not meant to be disseminated. It's a special request from Professor Lurka, so please do not share those patient videos. It's extremely important, it's for teaching. So you listened to a talk about childhood, brain development and how it influences childhood behavior. You listened to a talk about adults and how they present with psychiatric manifestations, but the problem is actually an autoimmune condition. And here I am to tell you a little bit about the aging brain. And what I'd like to emphasize is that neuropsychiatry covers the entire human lifespan. And what we are talking about is neurological causes for mental health conditions, as well as neurological complications and disability that are associated with mental health conditions. But we are also talking about psychiatric consequences of neurological conditions. So it's quite an important clinical spectrum, and it's one that we deal with not just in the clinic, not just in hospital, but also in community and public health, and hence therefore it's important. Now, what happens as you age? Most of the affected areas are what we call the polymodal and association cortices. We don't seem to have it projecting.
And so this was the birth of a very powerful collaboration between Buddhi Clinic and Apollo hospitals using something as simple as a health check. So when there is collaboration that is meaningful and when there is a coming together of partners who complement each other, we found that there are new ways to enhance what we have already been delivering to the patient. So borrowing the best of what they have and putting it together with what Apollo does really well, we have come up with this new premium health check. When any new product is put on the market, there is always a latent period for people to get aware of it and for the adoption to rise. So I think in the next few months, we will see that all these concepts will get integrated into our health check programs. And we will now have a very powerful health check program that looks at a patient who walks into our health check facility in a much more holistic way. So this is just one example that I can offer of how working with his team, Dr. ESK's team, will actually enhance the value that we deliver. And it is not just about this. We know that today chronic illnesses and non-communicable diseases have taken root in our society and are fast displacing the infectious diseases. 15 years back or 20 years back, our visit to the doctor was typically a short-lived encounter. You fell sick, maybe you had fever, you felt unwell, you went to the doctor, he gave you some medicine, 3 days later you were fine. And that was how we remember our interactions with doctors. These were episodes, in most instances, far apart. Today when we deal with this epidemic of chronic illness, diabetes, coronary artery disease, chronic kidney disease, now the relationship with your doctor is not an episodic one separated by months or years in between. This relationship is now a partnership. And the stronger the partnership, the better will be the outcome for the patient. So what do we mean when we say partnership? Whatever the doctor can offer you, and I was speaking to one of Dr. ESK's oldest patients, so I will take the liberty of quoting exactly what he said. He said 40% the doctor does for you. If he is a good diagnostician, he makes a good diagnosis, he puts you on the correct medicine, 40% he does. 40% the patient has to do. Making sure you follow the advice, making sure you participate in the treatment, making sure you escalate whatever needs to be told to the doctor appropriately. So 40% comes from the doctor, 40% comes from the patient, and 20% you have to leave to the Almighty. I think that's a fair summary of the kind of partnerships we are building today. So we need to walk together, doctor and patient, within the system to ensure that the patient gets the best possible outcomes. Because these are not diseases which can be cured. These are diseases which need to be managed. And in order to manage them effectively, we need new collaboration, we need more powerful collaboration, we need a transdisciplinary approach. This is a word I actually learned from Dr. Yeske because he uses it very often. So a transdisciplinary approach is the need of the hour. Just one last point I'd like to make, and this approach has to start as early as possible. So if there is a problem, the earlier it is diagnosed, the better is going to be the outcome. So with these few words, I'd like to again compliment Dr. Yeske and his team for putting together this neuropsychiatry roundtable. It's an absolute privilege for Apollo Hospital to associate with you, and I hope we are laying a foundation of a partnership that will get stronger as we go ahead. I'd like to thank all of you who've come here today to participate in the function, and above all, the speakers for today's function. Dr. Valsamma has travelled all the way from Sydney to be here with us, and so have our other speakers. So I think we will definitely benefit from their wisdom and their insight, and we will take something back from this function. Thank you.
Okay, sir.
Ideas, and it's my pleasure and privilege to be here. I thank Dr. Krishnamurthy for making me part of this roundtable curtain riser. Well, as Dr. Ravi was saying, and also while we were talking to Ludger in the evening, I think neuropsychiatry is one area where we need really to work, quite a bit, and we congratulate Dr. Krishnamurthy for doing this for quite some time now, before most of us have realized this. And we all know that there is nothing different from neurology and psychiatry. By and large, whatever we do, it's all the brain that decides what you want to do. And unfortunately, the misconceptions, misunderstandings the public have, of course, we also have contributed much to the misconceptions, making simple things more complicated. Because most of the times we do understand that we say that control your thoughts, control your emotions, but we never tell that control your diabetes, control your hypertension on your own. Indirectly we tell the person that it is your fault not to control your thoughts. It's your fault not to control your behavior. It's your fault not to control your emotions. I think this is a study of neuropsychiatry will give us a lot of insights into understanding why the people behave the way in which they behave. And I know it's a long way to go. As Dr. Sridhar said, that I think we need to work quite a bit in making it a holistic medicine, especially the mental health. The importance of mental health is not being given as much as it deserves to get. Because we all know that whatever decisions we take, whatever we do, it all depends on the mental health which we have. Why some people, in spite of the brilliance, don't succeed as much as somebody who is not so brilliant, for the simple reason that the capacity to judge is far greater than the people whose capacity to remember the lessons or
capitulate what they have read. So this is where I think the theories of neuropsychiatry or the mechanisms involved in various emotions, thoughts, behavior, judgments, intelligence, everything what we do every day in and day out. So earlier we realized that the better it would be for the world. After all, as we see in every day-to-day day-to-day news, something is happening bad somewhere, something crimes are happening somewhere, some anti-social elements are doing something. So these are all things which we need to work out. I know it's too big an area for a psychiatrist to do that. I think there are the social scientists to do it, the psychologists to do it. But for the psychiatrists, we need to give the basic scientific information that how the brain works. Like, let us say, the addictions. We all know that it is not simple that I get addicted. Why I get addicted and why my friend is not getting addicted. There is something to do with my brain. My reward systems are different. Why I like masala dosha and somebody likes jalebi is entirely what your brain decides. After all, the reward system asks you to do it again, again, and again, and again. So the pleasure involved in doing some activity, the pleasure principles or the pleasure areas, the chemicals that are involved in generating the pleasure within the body, it all decides why I should do it again. Not everybody does that. Somebody is not interested in food, somebody is interested in clothes, somebody is interested in something else. That means the stimulus that gives the pleasure to the individual is different. So the area of pleasure might be the same in every brain, but what stimulates that area is different for me, different for you, different for somebody else. Somebody enjoys reading, somebody enjoys music, I agree that over a period of time you tend to take the pleasure. Repeatedly you do it, most probably the pleasure gets reinforced, repeated. So these are all things which we need to study, and I think there is a lot of a journey to travel for neuropsychiatry. At present it looks a bit clumsy. Like the divisions which we have in psychiatry like schizophrenia, mania, depression, they may not be the categories which really they are. Perhaps a day should come where we have something like, I'm sure Dr. Ludger will be talking about, the autoimmunity, inflammations. So perhaps depending on some autoimmune mechanisms or inflammation or some area of the brain, they could influence the executive functions, they could influence the visceral functions, they could influence the emotional functions, they could influence the cognitive functions. So depending on which functions are affected by what type of mechanism, perhaps the expression of that would be depicted as an illness. Currently we are in a state where we do make categories like a few disorders, but unfortunately nature doesn't follow those categories. That's why you have some mood symptoms in schizophrenia, some schizophrenia symptoms in obsessive compulsive disorder, some obsessive compulsive symptoms in somewhere else. But for a lack of better classificatory system, for lack of better, nosological terms, we use this to communicate. There's nothing wrong in that, but we need to work on this further. I once again congratulate Dr. Krishnamurthy for making such a beautiful arrangements and also taking psychiatry at a higher level than what it really is today. And I hope Indian Psychiatric Society would take a leaf out of his book, would try to do whatever best we can do from that angle. And once again, I thank the organizers for giving me this opportunity and wish this conference a grand success. Thank you.
In doing research into psychiatry and neurology, I always thought that the cases are the most fascinating aspects of our work. And for that reason, I thought I'd present two cases to you. Neuropsychiatry is, of course, a broad theme, and you do have psychiatric presentations in many different neurological contexts, not only autoimmunity, but also in epilepsy, rheumatology, Parkinson's syndrome, genetic disorders, vascular disorders, whatever. But today I want to talk about, I want to present to you 2 cases with autoimmune disorders who turned out to have autoimmune disorders. And there's sometimes rather long way to get to that insight. And the whole story began with this paper, the story of the autoimmune encephalitis. So the insight that psychiatric presentations may be caused by immunological diseases really started in 2008 with the discovery of the anti-NMDA receptor encephalitis. And this, the first lady we discovered or found in 2009, my first patient with the NMDA receptor encephalitis. She was a 31-year-old patient who, until that age, so for 3 decades of her life, was perfectly fit and well, no history of psychiatric disorders whatsoever in the family. But then suddenly, out of the blue, she was working in a big company as the secretary to the big boss, and so she had a very high functional level. And then suddenly, within weeks, she developed hallucinations, delusions, paranoid ideas, and all began with a set of 3 seizures. So that was why, at the very beginning, everybody thought that must be something neurological. And so she was sent to a university department for neurology, where she was diagnosed based on the higher level of a university hospital, and they didn't find anything. So they referred her back, and they said, this is not neurological. And to give you an idea of what it looked like, I have brought you these 2 videos. And after that, she was treated for 2 years in different psychiatric hospitals in South Germany under the diagnosis of catatonic schizophrenia. And here below you see another. This is of course in German, but I have translated it to you like the other videos.
Schauen Sie mal zum Dr. Perl.
Am linken Arm jetzt bitte heben, hochheben, gut, ganz hochheben. Genau. Und jetzt locker fallen lassen einfach.
So you see here are catatonic features. The doctor tells her to lift the arm, and then he tells her to let go, but the arm gets stuck in the air. It's a phenomenon called catalepsia, and it's one of the earliest symptoms of catatonia, or catatonic schizophrenia. That's the way it was named at that time. And here you see how she moves the hand to the mouth, but then the hand gets stuck, and she kind of forgets to take it away, and she freezes. So one of the very classical catatonic features. Now, in these 2 years in different psychiatric hospitals, remember she had been investigated in the university neurological department, and they said there's nothing wrong with her neurologically. She was then treated for 2 years in psychiatric hospitals with many different drugs, and I just want to give you an impression of how many drugs they were. Then eventually she was referred to our specialized department, and at that time, in that neurological hospital, they already knew about these autoimmune neurological disorders, about the NMDA receptor encephalitis. That's what she was suffering from. But at that time, it was not known that the tests could be false negative. And when she came to us, I had heard that, and then I sent her CSF to Angela Vincent to Oxford, and she discovered that she was suffering from NMDA receptor encephalitis. And after that, we did all these investigations, including this PET imaging. And even though I don't expect you to be able to read PET images, even as a lay person, you can see, for example, if you look at this picture, that there is a strong difference between the right and left hemisphere in metabolizing glucose. And with the autoantibody finding and the PET image finding, it was clear that this lady was not suffering from catatonic schizophrenia, but from a neurological brain disease called anti-NMDA receptor encephalitis, a disease where autoantibodies in the body dock to brain structures and then in turn lead to dysfunction of the affected brain areas. You can see the dysfunction here, and you saw the clinical picture in the first movie. And then after immunotherapy, so after having learned that this is not catatonic schizophrenia, but rather NMDA receptor encephalitis, we treated this patient not with neuroleptics, but with immune therapy. And this just, again in German of course, but just to give you an impression of what she looked like later.
Ja, die Mädchen jetzt mittlerweile. Mittlerweile ganz gut. Es sind immer noch kleine Einschränkungen.
So I think I can stop it there, just to give you an impression that all these motoric symptoms were gone, and she was more or less healed. I mean, she did have some sensitivities to go into crowded places, whereas before suffering from this autoimmune encephalitis, she was loving to go to a village marketplace. Afterwards, she still didn't like it because it was too much, too loud, too many social signals for her. But apart from that, she was absolutely fit and well. Now, this is what I call a classical neuropsychiatric presentation, even though she had been diagnosed as suffering from schizophrenia. The whole story started with seizures, and that doesn't really belong to a classical primary psychiatric presentation. But there are also other cases, and that's the second case I want to present to you today, this evening. This is a lady in whom we too thought that it's rather primary psychiatric. A 42-year-old teacher and sport therapist. She had suffered from bouts of depression, age 22, 28, 32. Then age 35, she developed hallucinations, delusions, sexual delusions, and also delusional smells. And age 41, and 42, she had acute exacerbations of these schizophreniform symptoms. All her thinking was sexualized, so she always had to think about different sexual meanings. And this is an example of what she looked like in this state.
Am nächsten Tag weggefahren und er hatte am Morgen schon den Eindruck, meine Mutter hat das irgendwie gemerkt. Also ich kam die Treppe runter, meine Mutter sagte so, na, Hellei? So ist sie nicht zu mir, was sagt die zu mir? Und ich war so, oh. Ja, okay, ist das damit zusammenhängen? Das ist ja immer meine Fantasie war, der andere das merkt und so. Da dachte ich, ich habe noch gar nicht viel gemacht, also jemand muss beißen.
Well, I can cut it short at that time. So she was slightly fast in her thinking. And the whole content of her thinking, I could have gone through that video for another 3 minutes, and you would have realized that the whole content of her thinking was sexualized, and she couldn't stop her from thinking that everything she was seeing, every mimic, every facial expression was somehow related to some strange sexual thoughts. Now, the investigations in this lady were rather normal. She had, in the MRI findings, a slight temporal lateral atrophy. The EEG was slightly abnormal, but very diffuse. There was a diffuse rhythmic slowing, which you probably maybe you can see from afar. And the CSF was basically normal, apart from a blood-brain barrier dysfunction. But then again, that you see in about 20% of people. And then we had her as an inpatient 3 times. She also had Hashimoto antibodies, and with having this signal in the laboratory finding, you know that there are very few cases who may respond to cortisone. But since everything in this case was so classical for schizophrenia, I thought, well, if I start treating this patient with cortisone, I can almost treat 20% of my patients with cortisone. But having tried out the late last possible neuroleptic drug, clozapine, to which you responded but always got side effects, then after the 3rd admission we tried cortisone and then see what happened.
Ja, also ich bin sehr erleichtert und sehr froh, dass jetzt die Stimmen weggegangen sind seit ein paar Tagen. so Jahren. Ja.
Wie lange ist die Cortisonbehandlung zurück?
Die Cortisonbehandlung ist beendet worden vor 2 Wochen. Also die Infusion.